the march of the therapies, not just the hormone therapies, but also other therapies, has been to bring them earlier. And so we've seen that in two broad fronts, with a multitude of studies, and still some to come, where we're giving the agents that were previously approved in castration-resistant prostate cancer to patients with hormone-sensitive prostate cancer, and having an advantage in terms of survival that's fairly significant. And we now have data with multiple different agents. The first set of data we saw was with abiraterone in the patients with high-risk hormone-sensitive disease in the Latitude study, where there's an improvement in survival that's equivalent to giving docetaxel to that group of patients in a couple of prior studies. So that was a new option in that group of patients. And then in the Stampede study, they also documented with abiraterone in a broader group of patients that there was major benefit across the strata, but most particularly in high-risk patients, a smaller benefit in low-risk patients that's about 3 to 4% overall survival advantage at 36 months. And so from that perspective, the question is, do we give abiraterone to everybody that has hormone-sensitive metastatic disease? I would argue that we probably need to have pause in the low-risk patients, because the risk-benefit ratio may not be quite what we think it is, and those patients do have an excess risk of complications, particularly cardiovascular, from being on abiraterone. And we've seen that in the Stampede study, and also with recent reports from SEER databases suggesting that if patients have any cardiovascular disease before they go on abiraterone, they have an excess risk of death and also hospitalisation, most particularly related to cardiac issues. So we've had some advances. These drugs are coming earlier. Abiraterone is about to become generic in the United States, so it will be cheap.